Hello, everyone. So we've just now learned how to prepare the patient, cannulate, expose, open the atrium, close the atrium, and put in pacer wires. One of the first types of cases to do robotically is the resection of cardiac tumors, particularly the most common benign tumor of the heart, which is a left atrial myxoma. Now, these can be the size of a tiny pea all the way much bigger. And we want to share with you how to begin by taking out a left atrial myxoma. Let's take a look. One of the cases ideally suited for robotic cardiac surgery is the removal of a benign cardiac tumor called a myxoma. This is a 61-year-old patient who presented with symptoms of presyncope and abdominal pain, who underwent a workup and found to have a significant myxoma, fairly large in size, associated with pseudo-obstruction of the mitral valve. When the tumors are big enough, it can cause what's known as the tumor plop, where blood flow nearly obstructs entering into the left ventricle and then through the rest of the body. As you can see, there is a fairly substantive tumor, and so this is approached robotically. The patient is placed on cardiopulmonary bypass, and the left atrium is opened after cardioplegic arrest. And care needs to be taken here because as soon as you open, you can start to see this invading mass that is quite substantial. And the atrium is opened, as we've described earlier. Now, here's where it gets interesting. It's very important always to create a nice base or stock to avoid recurrence. And I'll walk through what that means. You can see the tumor essentially replaces the entire left atrium. And so careful utilization of our instruments and the dual blade retractor, somewhat unconventionally, starts the dissection. So you develop a plane that includes the muscularis or muscle layer of the left atrial wall as part of the resection. The good news is that the muscle is usually multi-layers, and as long as you find that plane, you can usually tease these out quite nicely. One of the signals that this is definitely a benign tumor is it's well circumscribed and the planes are fairly easy to separate. All done with sharp dissection, the same instruments that we've already described. And then once you're beyond that plane and the stock, then you can remove that. You can see taking off the entire endocardium with the tumor to allow that base to be matured quite nicely and avoid recurrence. Now, it's also very important, if possible, to remove the tumor in one swoop. So here it comes. And this is a soft tissue entrapping device that is placed through a port or working incision. And you can see the size of this tumor is quite substantial. Well, now that the tumor is out, small irrigation, making sure there's no other residual damage, the mitral valve is intact after turning the root vent off. And now we have the left atrium to put back together. I tend to use a suture called Cardinal. This is made by Peter Surgical that has a little bit more elasticity than polypropylene. Essentially, it's a polypropylene variant. And bringing the endocardium to endocardium here and then tying it. The suture is quite nice for robotic use. Now, once that's done, we close the atriotomy exactly as we've just shown in the last episode, where we bring endocardium to endocardium and epicardium to epicardium. And then secure it from the outside, followed by a 2-layer vertical mattress, much like we just showed earlier. These principles of atriotomy closure will recur in every single robotic atrial case. Again, completing at the level of the LV vent or the right superior pulmonary vein, and switching to the left hand, you can use the dual blade retractor to retract the SVC, which is a really nice way to facilitate excellent clear exposure of that sometimes precarious area to close the atriotomy. And then repeating to complete the atriotomy with good apposition of the endocardium and epicardium. Again, closing off the vents at this time, reversing the stitch to complete the final atriotomy closure. To complete the myxoma removal. Once the atriotomy is complete, in this case, we do not usually put in pacer wires for these types of cases, and then reanimation can occur with cardioplegia and weaning from cardiopulmonary bypass, with the confirmation postoperative echo revealing no residual valvular defects, preserved ventricular function, and moreover, a nice base fully resected with no evidence of residual tumor. So now we've seen how to excise a fairly sizable left atrial myxoma without trauma, creating an excellent base, and then repairing the left atrium. Now, the next episode, we're going to talk about a very important initial type of case to do is how do we manage atrial fibrillation, and join us where we're going to talk about the biatrial robotic Cox-Maze procedure.